Hello, hello. हाय अमीश।
सर कैसे हो।
अभी
मैं
फोटो
बढ़िया हूँ, हाउ आर
अभी
यू?
फर्स्ट क्लास सर, इतने बड़े बड़े लोगों के बीच में मैं हूँ।
क्या
मुझे अभी
क्या
से
क्या
पाल्पिटेशन
क्या
चालू
बात
हुए
है,
हैं।
क्या बात है अनीश।
अपना
Hi,
नाम बड़ा
Dr.
करने
Amish.
के लिए ये सब बड़े बड़े लोगों को बुलाते हैं साथ में।
We are good to go. Okay. Good evening and a very warm welcome to one and all. I am Dr. Vaishali Zamre, one of the team members of FSIBC. In association with Association of Surgeons of India, Breast Surgeons of India, we have been organizing webinars focusing on some niche areas in breast cancer. So today's is the seventh webinar in the series of master course in deep dive into breast cancer. And today we are going to talk about genomic assays. As we all know that genomic assays have actually transformed the way we plan the adjuvant treatment or the neoadjuvant treatment in breast cancer. In today's webinar, we are going to look at the science, the evidence, and the practical aspects of how we plan the treatment in early breast cancer, taking help of the genomic assays. So we have a wonderful panel of experts and great faculty. So I would actually start with Dr. Amish Vora. Dr. Amish Vora is a very well-known medical oncologist in Delhi NCR, and he is the director and head of medical oncology team at Hope Oncology Clinic in Delhi. And he is going to take us through the predictive and prognostic molecular assays shaping breast cancer care. Dr. Amish, over to you next.
Thank you so much, ma'am. I have my slides with Ravindra, but I will try to share. And in case if I fail, then he can pick up. Um Slides visible, and am I audible?
You are audible, but slides are visible.
Okay,
Now
perfect.
visible.
And it is moving to the next slide also.
Yes.
Perfect. Okay. Thank you. Thank you so much. In fact, as I said, I'm honored to be on this platform. I was given the topic of molecular assays for early breast cancer, and Dr. Safalta is the one who gave me this topic. uh, I asked her, talked to her, and whatever she told me, I have tried to prepare that in next 25 minutes. I will try whatever best I have understood about molecular assays. And we have one of the pioneers of these molecular assays amongst us, and she can always add on later if I have missed out on something. So, I felt this platform can also be with the students. So little bit of student centric. I have kept my talk. Genomic tests, we all know, are done on tumor tissue, and so-called genetic tests are normally done on blood or saliva. Now, this particular thing, when I was reading, I felt it carries a big understanding, which we will discuss a little later when I talk about the nuances. So, question is, why do we do these tests? These tests are personalized treatment decision making tests. So it's just a completely separate NSABP B18, and this was the one where the neoadjuvant chemotherapy versus adjuvant chemotherapy was studied. And what they found very classically, the patient with a complete PAT CR did better. Now, when I am sitting in front of the patient and I tell the patient, "Okay, look, I'm not going to operate on you, but I'm going to give you neoadjuvant chemotherapy. And based on this neoadjuvant chemotherapy, you have a 54% chance of achieving complete pathological response." Patient will ask me, do I belong to 54% or do I belong to 46% of the remaining? Now, we do not have an answer to that. We say, look, this is studied in a big patient pool and it all depends on how you do well. We cannot individualize the treatment decision. And that's when these tests come into the picture. They are further trying to individualize which are those patients who will do well versus and which are those patients who will do well with addition or deletion of the standard of care treatment. So I have given an example. 43-year-old female, clinically T2N0, IDC, went for surgery. Same PT2N0, the tumor size is 4.2 centimeter. ER is 8 by 8, PR is 8 by 8, grade 2, and no LVI, key 67 is 12%. Will you offer chemotherapy to this particular patient? If the patient is there in front of me without any molecular assay, I would be in actually two minds. I would say the tumor is 4.2 centimeter and patient is 43 premenopausal. I think I should give chemotherapy to this particular patient. Will some other addition of test will help me? Second, the same patient, age is 59, but grade is 3 and key 67 assuming is 20%. Will you offer chemotherapy? Again, postmenopausal T2N0, strongly hormone receptor positive, you say grade, I think, should we offer? Age is 63, grade is 1 to 2, key 67 is 40%. Now, again, the question is 40% key 67. Should I be offering chemotherapy to this patient? So, there are multiple case scenarios in our day to day practice when we are in a limbo whether to give or whether to offer chemotherapy to these patients. So these genomic tests allow me to individualize these decisions. It gives a score and chances of recurrence risk reduction with chemotherapy or any other treatment. But it is of paramount importance that this is discussed with the patient. Some patients are not wanting to take even 2% chance, while some patient may be comfortable with 8% chance of risk also. So, what are these genomic tests which are available, and we are talking about that? The most common, most widely talked about is Oncotype DX, that is 21 gene assay. Can assist, I have put can assist as the second one because of two reasons. One, we all are proud Indians. It is developed in India, which I feel with a different thought process, different ethos, and different way of looking at the tumor biology. Rest of all the essays are looking at in a particular way, while can assist tries to look at it in a different way. We have MammaPrint, which uses 70 genes. We have Prosigna, what is to call as a PAM50, uses 50 genes. We have Endopredict, which uses 12 genes. And we have BCI, that is Breast Cancer Index, which uses 11 genes. As you can see, none of the tests have uniformity amongst themselves. What are the scenarios where we normally order these tests? Majority of the time, in fact, more than 90% of the time, when the patient is hormone receptor positive, HER2 negative, early breast cancer, that is PT1, T2, some T3s, N0 or N1A, when we are not able to decide whether to offer adjuvant chemotherapy or not, I have highlighted adjuvant chemotherapy because the new adjuvant data is still not mature enough. Whether to give extended hormonal therapy beyond 5 years. Till now, in my clinic, I look at it any patient who required chemotherapy in adjuvant or neoadjuvant setting, I would like to give them extended hormonal therapy. We have multiple trials. We will not go into the details of that. BCIS, whether to offer radiotherapy in this BCIS patient or not, is the time when we would offer them these tests. When would we not offer molecular test in our patient? When HER2 is positive, we do not offer. When 4 or more lymph nodes are positive, when HR is negative, there is one test which has studied but not well accepted worldwide. So we restrict ourselves to HR positive. Now, predictive and prognostic is the title which was given to me. Prognosis is how will the disease in this patient behave. Predictive is how will this particular treatment work. As for example, ER, HER2, these are predictive. ER है, मुझे हार्मोन देना है, पेशेंट को फायदा होगा. HER2 पॉजिटिव है, I need to give anti HER2, it will be positive. While grade 3 Ki67 are prognostic, they are not predictive. Similarly, PD-L1, we will not go into the details of PD-L1 here. Many tests are available. Which one to choose? So we will try to get into details of two tests, Oncotype DX and CanAssist, which are widely used in India. There are other tests also one can read or we can discuss later if the time permits. None of my lecture as guided by Dr. Shyam Agarwal once is complete without NCCN guidelines, and these guidelines I have downloaded today morning. So if a patient is premenopausal, PT1 to T3, that is surgery is done, and node negative, determine if patient is candidate for chemotherapy. Here, if you look at it, they only recommend 21 gene RT-PCR assay. This is category 1 recommendation. My point is, I would like quickly to go through the rest. If the test is not done, we are supposed to offer chemotherapy. If the test recurrence score is 16 to 25, we offer chemo. More than 26, we offer chemo. Actually, it is just a small subgroup of less than 15. And the score keeps varying based on the test, as we would see. And that's the reason many a times I am reluctant to do any of the genomic assay in a premenopausal female. If the patient has 1 to 3 lymph node positive, suddenly the guidelines change. You can do any gene expression assay. They do not recommend that it is only 21 gene assay, which should be category 1. This in their particular NCCN table, and I am sure very soon a time will come when they would include can assist also here. But here, if you see predictive and prognostic, fortunately, unfortunately, whatever the data right now says, Oncotype DX is both predictive and prognostic, while Mamaprint, Prosigna, and Endopredict, the predictive value is not determined. All are prognostic. You can take anyone to say how the patient is going to do bad. But in terms of the predictive effect of this particular test, Oncotype DX right now has the highest data. BCI, breast cancer index, is a completely different aspect. We will not be able to go into the details of that. So Oncotype DX scores over others. So very quickly, journey of Oncotype DX. 2004, there was the first publication, and this assay was created based on expression of 250 genes. What they used was they used microRNA and RT-PCR technique from 447 different tissue samples, which from the patients which were put on NSABP B20 study. Out of these, 16 genes were selected based on statistical association with breast cancer recurrence. Now, these were ER signaling, proliferation, HER2 amplification, cell invasion, blah, blah, blah. In addition to these 16, 5 more housekeeping genes were added basically as a control to create an algorithm. Please remember, there are two things which I wanted to say. 60% of genes are related to ER module. 60% of genes are governed by ER module. It may give a very good predictability, or it may be giving false scores if the tumor is not ER oriented or ER dominated. And second, I was surprised to know that Oncotype DX is done on FFPE, not only on isolated tumor cells. On blood cells also it can be there, on mesenchymal cells also these tests is done. Probably at that time they decided to do it on FFPE, not isolated tumor cells. There are 4 retrospective studies and 2 prospective studies on Oncotype DX. During from 2004 and 2015, the utilization of Oncotype DX increased from 1.5% to 34%, with a decrease in chemotherapy usage from 42% to 36%. In addition to this, people who did Oncotype DX are the ones who lived longer. What association was that? We really don't know. That was what was seen. Quickly, we will go through the 2 prospective studies, Taylor X and RX Ponder. Taylor X is the first in 2018. I remember Dr. Sareen had come from ASCO and she told Amish, तुम्हारा chemo सब में नहीं चलेगा अभी. You can't give chemo in all patients. Look at this. It has changed the world. So this was 21 gene expression assay in N0, not in node positive. And this was Ponder X. This was in node positive breast cancer. So in Taylor X, what did they do? They took out a cohort of 10,000 patients where Oncotype DX results were available. They selected the patients where the recurrence score was between 11 to 25, randomized into chemo hormone versus hormone alone. And at the 5 years, what they saw was the line were exactly superimposing. What it meant was that 11 to 25 recurrence risk score do not offer chemotherapy in addition to endocrine therapy. And this is the 12 years update. And as far as I read, this is 11.5 years of follow up, and there is no difference in overall survival. There was a difference in 5 year survival. There was a difference in breast cancer related survival, but overall survival, there was no difference between whether you used Oncotype DX or not. In addition to that, women less than 50 years, again, RS was 16 to 25. They selected 11 to 25, and now it is 16 to 25, where the chemo helped in premenopausal. This was a new finding. What is the significance? I really don't know. This was the node positive, and as it was predicted, in a premenopausal, chemoendocrine therapy helped as compared to endocrine therapy alone. Lot of discussion about PonderX in the various forms. Now, what are the controversies with Oncotype DX and few other hormonal assays? The real world data sometimes differs. Manufacturer has changed their recurrence score and their classification of low, intermediate, and high multiple number of times. There is a low representation of African and Asian population. I always said the cost of 4 cycles of TC is much less compared to Oncotype DX, and premenopausal population still no clear-cut consensus. This was the AI summary of Oncotype DX. My take on Oncotype DX is it is very useful when I want to plan when not to give chemotherapy. It is helpful in postmenopausal, when to offer and when not to offer. In premenopausal, I strongly look at the clinical correlation, not just on Oncotype DX, before I decide whether to offer chemotherapy or not. Last 5 to 7 minutes, I will talk on CanAssist with a very proud feeling. Dr. Manjari Bakre, she is here on this platform. I didn't know she was going to be on this platform, ma'am. She's the scientist from Indian Institute of Science, Bengaluru, and she founded OncoStem and this test. It was needed because we wanted a cost-effective, reliable genomic test for Indian patients. OncoStem spent 5 years, 2011 to 2016, to collect samples from Rajiv Gandhi, from Tata Memorial Hospital, from Bangalore, to validate and test their genomic test, and they officially launched in 2016. Philosophy was to go beyond the proliferation markers. Instead of RNA expression studies, CanAssist uses 5 biomarkers, which signifies metastasis, tumor resistance, and stemness of tumor. They also use 3 clinical parameters. It further uses AI-based algorithm to come out with a score of 0 to 100, where 15.5 and below is low risk, and more than 15.5 is high risk. 7,000 odd patients, India, Sri Lanka, Bangladesh, UAE, Saudi Arabia, Turkey, and Iran have used, and they are still regularly using. This was the 5 test, and this was the pathway. We will not go into the details of these pathway, but this was the validation study which was accepted in February of 2019, and what they found basically is that if there is a high risk, then patients, it can be predictive and prognostic both. If it is a low risk, again, you can basically it mimics the other genomic assays. And the same thing, if you see the graph C, it was seen in node positive patients also. I would strongly urge everyone to please go through this real world data of canasis, which is published in Nature Journal in 2025. What they have said is the real world parameters of patients who have used canasis is such a wonderful and a detailed thing. We do not have right now time for that, but I really enjoyed reading this. My take on CanAssist is very well validated genomic test for early breast cancer T1, T2, T3, N0, N1 with HR positive, HER2 negative biology irrespective of Ki67. Developed, tested, validated by an Indian cohort of patients. There is a different technology, different thought process as compared to other genomic assays. कॉस्ट इफेक्टिव एंड टैट ऑफ 8 to 9 days. 8वें दिन मैं चिल्लाना शुरू करता हूं एंड आई गेट द रिजल्ट बाय इवनिंग. I would consider in almost all of my eligible patients. Why I said almost? Because everywhere can assist is mentioned as alternative to other genomic assays, and that's the reason for medical legal purposes. That's why I've written almost. And my final conclusion for this talk is genomic assays is a very good science, is predictive and prognostic for early breast cancer with HR positive disease. Oncotype DX has highest amount of research and well accepted across the world. It answers one main question: should we or should we not give chemotherapy? BCI is the only assay which tells us about the extended use of hormone beyond 5 years. MammaPrint is a good essay. One day we can discuss in detail about the development of MammaPrint. It's good phase 3 data, more accepted in Europe. You can use it in your practice. The only thing is, as I mentioned, the predictive value of MammaPrint is not well determined. Up to 1 to 3 lymph nodes positive, we can use these genomic assays. Oncotype DX as category 1, while this is again my thought, can assist as an Indian originated test, also has a good retrospective data on the same. Premenopausal females with high risk features, I would be cautious while using genomic assays. Thank you so much. My apologies. I constantly spoke for 23 to 24 minutes.
Not at all, Dr. Amish. It was a wonderful talk. In fact, you made it so systematic and very easy to understand. I mean, I learned a lot, especially the developmental stage of all these essays. And thank you so much for that. I would request you to please stay with us because we need you during panel discussion as well. So thank you. And you've made my job easier by introducing Dr. Manjiri already. So next speaker is going to be Dr. Manjiri Bakre, who is a founder and chief executive officer of OncoStep Diagnostics. And she will, Dr. Amish has already discussed about CanAssist, but she is going to take us through the details of CanAssist, what it is, the science, how it was developed, and what is the current level of evidence about CanAssist. Dr. Manjiri, over to you.
Yes, yeah.
Yeah.
Thank you, Dr. Vaishali, for having me here, and Dr. Amish, thank you so much for really introducing the test. You made my job much easier, so I don't need to really rush through all the data. So thanks a lot. So the title of my talk today is Prognostic Assays in Breast Cancer and for personalizing treatment decisions. And I'm going to focus on CanAssist, which is a proteomics-based prognostic assay as against Oncotype or MammaPrint, which are all genomic-based prognostic assays. So this is just to make those fellows, etc., who are listening to my talk for the first time, to really give the timeline of what it takes to develop something like this. This is really not a fly-by-night, overnight job. So I started OncoStem Diagnostics in 2011 of March 2011, and these were this major milestones I've written from 2011 to 2020 till date. And these are major milestones we actually need these years with the employees we have had all these years. So it just continues, just work wearing multiple hats at all times. But really, without the investors and without all of you and hospital administrators, those in medical records division to give us the follow-ups, etc., this would not have been possible. So I really want to thank and all the questions that you have always asked and pushed us to really get to where we are. So thank you all for all of these this thing, and thank you enormously to my entire team, multiple employees throughout the journey of OncoStem. So this is just to showcase you, after incorporation, we collected samples for almost first 3 years, continuously started developing the algorithm. It does take, this is the AI-based algorithm. It went through multiple iterations of the learning, and it took us almost 1.5 years to finalize the model, statistical model. Then we got all the accreditations and we started Canas's Breast commercial sales. And we got all the accreditations in the process. We published, we did all the US and European studies. We continued to publish all of them and also present in different conferences. Then in 2022, we started working with Zydus on an exclusive basis to do sales and marketing partnership. And the post that we also did a validation of Canas's Breast in team trial, in ideal trial, which I will not talk today because the data is under review in a journal, but I'll just tell you what it is. And Canas's Breast, fast forward 15 years, Canas's Breast in ABSI, AGOS, ISMPO guidelines, and we have crossed more than 10,000 patients who have used Canas's Breast, and treatment has been planned based on that. So as you all know, and as Dr. Amish has said, goal of prognostication to really understand the underlying tumor biology of the tumor. Two women with 2-centimeter tumors, one may have a recurrence, one may not. Why? Because the one who has had recurrence has a aggressive biology, which is the need of the hour to understand beyond what is already done today. That is knowing TNM, age of the patient, hormone receptor status, HER2, and tumor grade. So prognostic tests like Oncotype, MammaPrint, Prosigna, EndoPredict lead the way in the West. However, there are differences between breast cancer patients in Asia versus Caucasians, on which all of these tests were developed. And major differences, as you all know, is median age and diagnosis in Asia. I've even given this talk in Middle East, and they all say our patients are also perimenopausal 48, whereas in Caucasians it's primarily postmenopausal 55 plus. We have higher tumor burden at diagnosis, with typically 1 centimeter tumor, one lymph node positive, 2.5 or 2.2 centimeter tumors. Whereas in the West, when we get this, even the path reports, it's beautifully to see screen detected cancers, 0.2 centimeter, 1 micromet, 1 lymph node with micromets. Really, such path reports are little on the rare side in India. And typically in our case, in India, it's symptomatic detection. So our problems are really the disease onset is at a younger age, and we often have patients who have majorly one node, majority of the times 1 node positive, grade 3 disease, high Ki67. So we felt that we need a test that will look at the underlying tumor biology based on our patients' tumor tissues, which are representative of not only the tumor biology but also age, because it's coming from these young women. And so that is why this is exactly why we started developing this. And I spoke to many clinicians even before starting, and they all agreed that yes, we would like to use, but having a right test, as well as it will fit our patients pockets. That is because majority of the times ours is out of pocket expenses, so it should be a cost effective test which will also be developed on our patients tumor tissue. That was really the goal behind why I started this, and that was really the rigor throughout entire this development and validation. We were very lucky to have an excellent statistician, Lubomir, who developed the statistical algorithm for us. He's a US-based biostatistician who is actually from Serbia. And he really developed, he worked with us throughout almost 2 years, and I'm still in touch with him. He is just excellent statistician, and he has developed a really well, the algorithm has learned very well through the data we have given and high profile data, thorough data that we have received. What is Canas's Breast? We look at Canas's Breast is an immunohistochemistry-based prognostic test, in which we do immunohistochemistry for 5 biomarkers: CD44, ABCC4, ABCC11, N-cadherin, and pan-cadherin. And then these slides, IHC is done on automated Roche Ventana platform, and slides are graded by our well-trained oncopathologist only at OncoStem in Bangalore. And then that information, along with 3 clinical parameters, goes into machine learning based algorithm to give us a risk score between 1 and 100. And the risk score cutoff is at 15.5. We have always had the same cutoff right from the start. We have never changed our cutoffs. So at 15.5 or lower, risk score is considered as low risk for breast cancer recurrence. Typically 70% fall in this, and 15.6 all the way to 100 is considered as high risk for breast cancer recurrence. And these biomarkers, as I think Dr. Amish also showed this, these really play critical roles in tumor. Why does the tumor breast cell, tumor cell in the breast, why does it travel through lymph nodes, and how does it do it to go and metastasize in bones, in ovaries, in uterus, in brain? So the tumor cell per se is not able to do it unless it acquires certain properties. And these are the properties such as epithelial to mesenchymal transition, loss of adhesion, invading into the vessels, and then after dislodging it somewhere else, but again become epithelial, that is mesenchymal to epithelial transition, and then acquiring chemo resistance in the chemotherapy resistance in the process. These are all the virtues, or in other words, lack of better word, the cell needs to acquire to really form another tumor. It's quite an hostile feature to really form a tumor in another part of the body, but they do this via multiple signaling proteins, and these were the 5 critical proteins involved in variety of signaling pathways that our statistical algorithm zoomed down into from a set of like almost 30 to 40 protein biomarkers that we looked at while developing the algorithm. And this is, for those who don't know, this is how CAN-Assay-based report is sent out. This is our calibration curve. We show very clear low versus high distinction. There is no in-between intermediate risk zone. And these are the 5 IHC images along with the H&E image of that particular tumor on which we perform CAN-Assay-breast. Now, once you develop a test like that, you need to show analytical validity of the test and global validation, clinical validation of the test. I'm not going to go into analytical validation of the test today. It is all published. The proof of the pudding really lies in validating CAN-Assay-breast or any test that is developed in different cohorts across the globe. So we worked with not only about 10 to 12 different hospitals across India, because India per se is also a very diverse country. Populations from Kashmir to Kanyakumari and Mumbai to West Bengal will be very different. So we try to encompass as much variation as that is there in India itself through working with multiple hospitals. We also knew that tomorrow when we go to different countries, having validation in countries outside of India, outside of Asia will be critical. So we validated in 3 different studies in the US, and one more is underway. And we also validated CAN-Assay-breast in Spain, the Netherlands, Germany, Italy, Austria, and recently also in Turkey. And that data is actually under review as well in the final review. So today I'm going to showcase you the data for all of these studies together. So how does CAN-Assay-breast work? So CAN-Assay-breast essentially generates actionable risk groups, and these are only 2, low versus high. There is no intermediate risk zone. So here is a typical Kaplan-Meier survival curve, where on the y-axis you have distant metastasis-free recurrence interval, and x-axis is time in months. So patients who were, this is the pool data, all the studies together. These were patients who received chemotherapy plus endocrine therapy. And when CAN-Assay-breast segregated them based on we did CAN-Assay-breast on all of these tumors, and then we looked at the risk scores and segregated them as low risk versus high risk. And then if you look at their outcomes, you can see that the CAN-Assay-breast low risk, which is about 70% patients, they have an excellent distant metastasis-free survival of 94%, as against CAN-Assay-breast high-risk patients who have a record and their DMFS or DRFI is down to 82%. Now, you may think that these patients would have benefit of chemotherapy given to improve their survival. which is very valid. And therefore, we looked at patients who received only endocrine therapy. There was no interference of chemotherapy in this subgroup analysis, where patients were only treated with only endocrine therapy. And even here, Canasis is able to segregate low risk from high risk, statistically highly significant, and the low risk patients do exceedingly well at 95%, whereas the high risk patients do worse at 84% in comparison to low risk patients. So this goes to show that Canasis is able to find these patients who were given only endocrine therapy for reasons I don't know exactly, but maybe small tumors, elderly patient, lymph node negative, low Ki67, etc. But it's not just all of these parameters that decide the aggressiveness of the tumor, and therefore you need to know the underlying tumor biology to treat them in a most optimal manner. So these are all the questions all of you have asked us over the last 10 years, and so I'm going to systematically answer all of them. Since most of our patients are one lymph node positive, how is Canasis best helpful in such a situation? Does it work differently in lymph node negative versus lymph node positive patients? How does it segregate lymph node negative clinically low risk patients? So we looked at the lymph node negative patients who are typically considered clinically low risk, whether they were treated with chemoendocrine therapy or endocrine therapy alone. The low risk patients significantly did better than the high risk patients consistently. And as you can see here, the graphs are highly significant, and low risk percentage is always about 70 to 80%. And in endocrine therapy treated alone, it goes up all the way to 90% as well. And the survival is always exceedingly well in the low risk, about 95 to 96% in comparison to the high risk patients who do far worse. So this goes to show that yes, even in clinically low risk node negative patients, you can have up to 10 to 18% patients who are actually at high risk of recurrence, and they may benefit from adding chemotherapy here and maybe additional drugs in this population if they are high risk for breast cancer recurrence as per Canasis Breast. Next, we also looked at T1, T2 node negative patients. So T1 node negative or T1, T2 lymph node negative patients. And in both these patients as well, once again, we do see 7 to 9% patients who are at high risk for breast cancer recurrence, and they do worse than the low risk patients who are at 96 to 97% in DRFI. And these were significantly higher numbers of patients in low risk disease. Now, what about Canasis Breast? Will it help in T2 and node positive disease? So these are typically the Indian scenario patients we see. That's why we also have from India the data we have. Majority of them have 2.2 centimeter tumors with one lymph node positive. So we looked at all the patients who were lymph node positive separately, a subgroup analysis. And as you can see, patients who were lymph node positive, which is typically, and this Canasis Breast is only meant for N1 disease, that is up to 3 lymph node positive. So when you look at patients who had N1 disease and treated with chemo plus endocrine therapy, you can see that the low risk patients are at 92%, and these are 51%, and the high risk patients are 49%. The percentages do change based on the node positivity. In the previous slide, I showed about 80% low risk and 90% and 20% high risk. But in lymph node positive, it's about 50-50, but the low risk patients do far better than the high risk patients. And the same was true even in patients who were node positive and treated with endocrine therapy alone. Even here, the low risk patients did far better than the high risk patients, and statistically significant segregation using Canasis Breast. Again, another questions we were asked is, how about most of my patients are young? Can this test work in a premenopausal patients or perimenopausal patient? So we did another subgroup analysis where we only looked at patients who were under 50. Now, since this was a retrospective data analysis, we really didn't have exact patient's menopausal status written in the notes. So we are not sure. So we looked at age cutoff of 50, which is what even Oncotype and most other prognostic tests use to suggest premenopausal. So we looked at patients who were under 50 years of age and treated with either chemotherapy plus endocrine therapy or endocrine therapy alone. As you can see, the percentage DRFI in low risk is always better, 93 to 90, typically 93%, and the DRFI percentage in high risk is much lower at about 80%. And here the segregation is 63% low risk to about 37% high risk. And these were patients treated with chemoendocrine or endocrine therapy alone. Then we also looked at patients who were young and were lymph node negative or lymph node positive. And as you can see here, the patients who were young and lymph node negative, the low risk patients are significantly higher numbers, 85%, and have 94% survival, and the high risk patients have 84% survival. When it comes to node positive disease, lymph node positive young patients had the low risk. Young patients with lymph node positive disease survival is still 90%, and the high risk patients they are at about 78%, indicating that these patients and all of these young patients in this subset, most of them have received chemotherapy. So what we want to really showcase is, for young premenopausal patients, it's not only the chemotherapy, but you need to, even beyond chemo and endocrine therapy, patients do have a higher risk of recurrence. So these patients who are CANASys-based high risk probably deserve something more. And now we do have this kind of therapies available, whether it is CDK4/6, PIK3CA, or imlunestrant, all the CDK inhibitors that are CDK4 inhibitors that are coming out. So these are the additional drugs that you can potentially perhaps think of using in an adjuvant setting to really curtail the risk of recurrence for these young high-risk node-positive patients even further. Again, not to give to every patient, but to the CANASys-based high-risk patients only. What about patients under 40 years? I remember distinctly one clinician asking me this question. And so we looked at data. This is primarily European data, who were under 40. And systematically, they were treated with chemoendocrine therapy plus ovarian function suppression drugs. And it was so interesting to see this data, very uniform treatment. And patients who were under 40, the low-risk patients with all of these treatments did exceedingly well, whereas the high-risk patients still have had recurrences down to 78%. So these 38% CANASys-based high-risk patients, even after OFS treatment, were high risk. So perhaps these are the patients who would probably need something more in an adjuvant setting to improve that 78% all the way, up to at least in early 90s. So here, segregating them again by CANASys-based certainly will help to spare the CANASys-based low-risk patients who are doing well. Now, as you all would agree with me, the early breast cancer patients do have a risk of breast cancer recurrence till 10 to 15 years from diagnosis. So until now, whatever data I showed you was validation of CANASys-based in retrospective studies to predict risk of recurrence in 5 years from diagnosis. Because going beyond these 5-year data in retrospective studies is very hard, because patients leave, the files are not kept, or whatever may be the reasons. So for these kind of things, you really need long-term, to get the long-term data, you need trial data. Patients who have participated in some trials, and those data are maintained by those companies very well, or those study trial groups. So in India, we really don't have such a precedence. And so we talked to multiple organizations who have conducted such long-term trials, long-term studies in the US and in Europe. And one such center is, one such trial was TEAM trial, tamoxifen exemestane adjuvant multinational. That was a trial run across 12 countries in Europe, and the Netherlands was one of them. And they had 10-year predictions, samples which were preserved for 10 years, and patients follow-up were available for 10 years. So we asked them if they would share those tumor tissues with us to assess if CANASys can even predict 10-year distant recurrences. And to everybody's great pleasure, we could see that CANASys-based high-risk patients do exceedingly worse than CANASys-based low-risk. And these are different curves these are called reverse Kaplan-Meier curves. And if you want to see the similar curves that I showed before, here is a TEAM trial data in which CANASys-based in node-positive patients at 10 years from diagnosis, Low risk patients are at 89%, high risk patients are at 69%. So, and even in endocrine therapy treated alone group, the low risk patients do exceedingly better than the high risk patients, and all these curves are statistically significant. Even the Dutch team was so excited to see this data. They have they themselves said that we will give you ideal trial samples, which has samples for patient follow-up from 15 years up to 15 years from diagnosis. And currently that's the trial that is completed and under review. So I won't be able to show this data, but long story short, Canasis can predict recurrences up to 15 years from diagnosis as well, and in a backbone of ideal trial where extended endocrine therapy was given to patients for 5 more years from after the standard completion. So again, one other question we often get, and Dr. Amish also talked about it, like, how do different tests compare with each other? So we tried to compare Canasis breast with Oncotype DX, MammaPrint, Key 67, Predict, and NPR. These are online tools, and Key 67 I think everybody knows. In the interest of time today, I only go in detail of Oncotype and MammaPrint comparison with Canasis breast. So we did a head-to-head comparison. Tumor tissues that were treated, that on which Oncotype was performed first, and patients were treated based on Oncotype DX were sent to us, and we did Canasis breast on that in a double-blind manner. And you can see and we assessed the concordance of Canasis breast with that of Oncotype DX in different Oncotype DX risk score cutoffs. This is the original cutoff of Oncotype, and these were the post-TAILORx, that is 1 to 25 and 25, 26 to 100. So as you can see here, the low risk concordance between Oncotype and Canasis breast is about 82 to 83%, no matter which risk scores you are comparing it with. And more importantly, because this was retrospective, we could get outcomes of these, and the accuracy of Canasis breast and Oncotype DX is very similar. It's in the early 90s in the low risk. So this goes to show that Canasis breast has excellent concordance of 83% with low risk of Oncotype DX, and patients of the low risk who were for whom chemotherapy was withheld are doing well at the end of 10 years also. What about MammaPrint? We also did a similar comparison from the European cohort, whose treatment was planned per MammaPrint, and Canasis breast was compared in the low risk. As you can see, MammaPrint and Canasis have low risk concordance of 83%, and in high risk, the concordance is at about 58%. All of this data that I spoke today is published in these many 16 publications, and all of these are available on our website with the downloaded files as well. Now, is Canasis breast in any guidelines? Yes, we are in Asian Geriatric Oncology Society's ISMPO, and as well as ABSI, Association of Breast Surgeons of India guidelines. Now, all this may be good, but is Canasis breast helping patients in India today? So this is why really we have been following patients who have been treated based on Canasis breast. I must have, me and the team and the sales team would have written to many of you to give us follow-ups of these patients. These are the valuable details that we must have. And Canasis breast is in clinical use across India since 2016. More than 800 doctors have prescribed it for more than 10,000 patients till date, not only in India, but outside as well. And this is the map that showcases how Canasis breast is sold in India. Canasis breast is also reimbursed by these many agencies to the patients. It is still not a complete this thing. It is still on ad hoc. It's case by case basis, and we are trying to work with the government or with the insurance companies to do it as a for every eligible patient. Canasis is also sold in these many countries outside of India: Turkey, UAE, Sri Lanka, Bangladesh, Iran, and Kingdom of Saudi Arabia. Many of you have used Canasis breast for 200, 300 patients in individual institutions, and publish all of these papers either by yourselves or pooled together. And it's really gratifying to see this data coming out, and it's coming out from all of you. So this is just in short the real world data of Canasis breast. Till now, till December 25, this is the cutoff is December 25. Out of this 9,572 patients for whom Canasis was used to plan treatment, it's typical 70-30 segregation of low risk to high risk. 99% plus are women patients, but we do have 66 patients who are male breast cancer. Under 50 were 27% patients, and T2 tumors were maximum. Node positive disease was 19%, and node negative were 81%. And grade 3 disease, histological grade 3 were about 19%, but majority are grade 2. And the final this is really interesting data I wanted to just show to the about the histologies. So Cancer really doesn't understand what the underlying tumor is is classified as based on histology. So we looked at, interestingly, again, and somebody asked us, can I use this test on micropapillary tumor? So we looked at all the data we have had prospectively, and you can see while in IDC and ILC, the segregation is about 70-30. And in mucinous, it is even like low risk is higher, 81 to 19, but in mixed mucinous, it is 71 to 29. So the high risk patients are more in mixed mucinous, and same trend we see in micropapillary over papillary. High risk patients are higher. And while we do not input the histology in the test, the biology of the disease is different, which is captured using the 5 biomarkers we have selected. And therefore, we do see higher number of patients segregated as high risk in these two slightly aggressive disease histologies. Now, coming to the final proof of the pudding is in the eating. So while 10,000 patients have used, and test is continuously getting adopted, how are the outcomes looking? So we are following every patient who has finished 5 years, and this is the data of patients who have finished 5 years. The treatment was planned based on Cancer-based risk category. The compliance in managing the treatment is about 90%. And Cancer-based low risk, which were about 73% patients, are doing exceedingly well at 98% survival compared to the distance recurrence-free interval, compared to the Cancer-based high-risk patients at 91%. And this is really, when we saw this data, we were really happy, and we continue to follow these patients. And this is really, this shows that Cancer-based low risk, which are 98% survival, this should really give you also confidence in using the test. Cancer-based is gaining momentum across the globe. Cancer-based data has been spoken by Dr. D.G. Vijay in St. Gallen's in last year, March, Dr. Tanesha in Istanbul 2024, October. And many of you have also presented. I'm not going to the previous presentations. It is also presented across all the major breast cancer specific conferences, or ESMO Breast, ASCO, APBCS, and also San Antonio Breast Cancer. So to conclude, Cancer-based is a proteomics and AI-based prognostic test, which is validated on Asians as well as Caucasians. Performance, it is performed as a service today in Oncostem Central Lab and reported in 8 days from receiving sample in our lab. Cancer-based will help you in not only intermediate Ki67, but in grade 3 disease, in T2 node positive, T1 node positive disease, who are the patient may be pre or postmenopausal disease. And in real world, the data accuracy shows 95%. Cancer-based is included in multiple guidelines. And so to summarize, I would say we have showcased today the retrospective evidence of Cancer-based segregation, prospective randomized team trial data that was shown today. And we have also showcased the real world data. And I stop here and happy to take questions. Thank you all for your attention.
Thank you, Dr. Manjari. It has been really heartening to see that the Canasys data is actually growing day by day. And since I've recently heard you in Mumbai as well as now today, I'm sure, as Dr. Amish has predicted, very soon we will have Canasys included in international guidelines as well. Obviously, we will have to work hard to collect further data on it, and the validation process will have to be much robust. So we will not take questions for you right now. I think all of these questions will be addressed during the panel discussion. So thank you so much. Please stay with us. And now I will hand over to Dr. Prekshi, my colleague, to take the proceedings further. Dr. Prekshi, over to you.
Yeah. Thank you, ma'am. Good evening, everyone. So after these two wonderful sessions, now we'll move towards the panel discussion. My request to the delegates, you can put your questions in the QA box, which we can discuss after the panel discussion. So first of all, I would like to invite the moderator, Dr. Amol. He needs no introduction. Can you please share this slide, Sunidhi? The intro slides, please.
Yes, ma'am. Sharing. Actually, Dr. Amol has shared their slides.
Uh,
I hope I'm visible and my slides are visible.
Slides are visible, Dr. Amol, but you are not visible. So the screen is dark.
I'm not visible.
So it's dark.
Okay,
So
at least
let
my
me just
voice is
introduce
coming, right?
the moderator and the panelist. Dr. Amol, he is senior consultant, medical oncology at Fortis Hospital, Mumbai. Then our previous speakers, Dr. Amish and Dr. Manjari, they are very well staying with us for the panel discussion. Dr. Safalta, senior consultant, Amrita Hospital. Dr. Neha Garg, senior consultant and HOD, medical oncology at Andromeda Hospital, and Dr. Veda. I hope she has joined. She was just on her way. So, Dr. Veda.
Joined. I'm here.
Oh, welcome, Dr. Veda.
Yeah.
So she is clinical lead and senior consultant, breast surgical oncology at MGM Cancer Institute, Chennai. Over to you, Dr. Amol. But still, you are not visible. The screen is dark. Seems to be dark.
अमोल वो ऊपर ना एकदम टॉप पे एक छोटा सा इधर उधर करने वाला होता है. If you change that, you will be visible. See, I'm doing it for myself. You are exactly at this point what you see me, and then now I do this. I'm visible.
Am I visible by any means now?
नहीं रे.
So I think let me be invisible. We can
Sir,
start.
maybe
कोई
your
बात नहीं.
camera
अमोल, your
shutter has been
your
off.
voice is good enough for us.
Sir, maybe your camera shutter has been off.
That's what I
Yeah,
said.
I think
Camera
that
shutter.
is the reason, but I'm not able to keep it on by any means. Okay, I think we should start moving. My slides are visible?
Yeah, they are.
Yes.
Okay, so I think let me thank Dr. Safalta for inviting me for this case-based panel discussion, genomic test for early breast cancer. Myself, Dr. Mulkade, and today is 26th Feb 2026. We have Dr. Veda, Dr. Manjari, Dr. Amish, Dr. Safalta, and Dr. Neha, right? All of them are there. I hope so.
Yeah, they are.
Yes, everyone is there.
Yeah, so I have no conflict of interest, and this is meant so that we can learn from each other with the help of the clinical situations. Now, what options we have for genome-based tests, especially we are talking about the predictive tests. And the options are MammaPrint, Oncotype DX, then Prosigna, EndoPredict, and Breast Cancer Index. And as has been discussed previously also by Amish, that MammaPrint and Oncotype DX has the most robust prospective data, and as rightly said, the level of evidence is 1A. Prosigna, EndoPredict, Breast Cancer Index don't have much large data, few retrospective studies. So moving on, now this is, if there are any fellows or residents in the audience, we have already about 14 people, but anyways, the current controversies in the use of Oncotype DX in early breast cancer is a very beautiful article recently published last year, Cancer Treatment Reviews, and I think one should go through that. So moving on, let us start with the clinical case. We have a 44-year-old female, T2 tumor, one node positive.
Dr. Dr. Amol, I am just interrupting once. The 14 people is on the faculty platform. All the audience is not visible on this part, but there are always usually close to 100 people on the audience.
Okay, I could not see them, so maybe. Yep. So should we continue?
Yes, please.
Yeah. So 44-year-old female, T2 tumor, one node positive, grade 3 IDC, Ki67 30%, post upfront surgery, and the surgeon was kind enough to refer it to you for chemotherapy decision. Last menses were 4 months back. She's ERPR, strong positive, HER2 negative. So, Dr. Safalta, let's start with you. Will you do genomic test before planning for chemo for this patient? 44-year-old T2 tumor, one node positive, grade 3 IDC. And she is definitely not postmenopausal.
Yes, so not a postmenopausal, premenopausal lady with node positive. I will not do any oncotype DX, and it has not helped in these patients. And with the K67 of 30%, I would straight away go for chemotherapy. In this
Dr. Amish, will you like to do any test, genomic test before planning for chemo, or you're also comfortable directly going for chemo?
I'm always comfortable with what Safalta has said, and I have been vocal in many of the national platforms that this particular subset of patients whom you have said, it's very, very, you can keep discussing. So my point is, in clinic, I would not confuse patient with doing any of the genomic assay. If the patient has gone for second opinion and have asked for Oncotype DX or any other genomic assay, I won't say no to them.
Okay. Anybody else in amongst Dr. Neha, are you there? Or Dr. Veda?
Yes, sir. Yes, sir.
Suppose the patient says, I have no cost issues. Doc, do some tests. Will you do it
No,
or we will not?
no, sir. Not recommendable. Even this type of patient will direct away go for the chemotherapy only.
She says, Doc, I don't want to take chemo. I will lose my hairs. Then
We'll try
also
to
you will
convince.
not. Node positive. One node positive, you will say that, oh, she has to take chemo.
Yes, sir.
Okay.
No,
So,
Amol, if the
yeah.
patient does not want chemotherapy, the
Okay.
guidelines unfortunately does not mention that. They mention whether patient is eligible for chemotherapy or not.
No,
That is
the
what the
point is
guidelines
that she
mention.
wants to have additional information. She says, no cost issue. I want additional information. If it is required, do the test. I have no cost issue. Then what?
There is no harm in then doing genomic assay, but my decision of offering chemotherapy will not change.
So if the patient says, I want additional information, no cost issue, which genomic assay you will do?
Right now, Oncotype DX is the one which I offer to patients. And if the patient says, "Kuch cheaper batao," then I offer
No,
Canasis.
there is no cost issue. You're in Delhi.
So Oncotype DX, because in one node positive, prospective study सिर्फ Oncotype DX पे है.
So you agree that at least for this subset of patients, Oncotype DX has the maximum data.
Correct.
And if there is no cost issue, you will offer that if the patient insists.
Correct. Absolutely correct.
Okay. What if the same lady has two nodes?
1 to 3 lymph nodes बोला है ना?
No, first was only one. How it has become
1
two?
to 3 lymph nodes है ना उसमें study में. So
Okay.
it doesn't change. It doesn't change because we have the data of 1 to 3
So
lymph.
as long as it is less than 4, you are okay.
Less than 4, we have the data. I am not okay in premenopausal or perimenopausal, as I mentioned earlier. But yes, we have the data to do the genomic assay.
Okay. So, Dr. Safalta, do you ever ask for any Oncotype DX or any genetic test of patient with 3 nodes positive if this patient is fit for chemo?
No, I don't ask.
Okay. So most of us don't ask for it, but if the patient insists, as Dr. Amish has rightly said, the maximum data, especially for this subset in a prospective trial is Oncotype DX, if the cost is non-issue, it should be offered. Now, the Oncotype DX was offered, probably surgeon advised, it has come as 19. The same lady, 44-year-old, 2 nodes, rest is same. Dr. Amish, the score has come, unfortunately, 19. Will you give her chemo or you will not?
No, why unfortunate?
Not unfortunate, I'll say fortunately.
No.
Fortunately, it has come 19.
Manufacturer of Oncotype DX are kind enough, and I quote kind enough to keep changing their score. And in PonderX, we have the data that 16 to 25, less than 50 years of age, benefited with chemotherapy. My only issue, Amol, if by chance you forget to mention, I wanted to learn from you. My only issue with Oncotype DX is there that linear correlation.
I'm coming to that. I'm coming to that.
Okay, perfect. I thought that you will come to that, but you'll have to teach us.
No, so but just I just wanted to ask is with the
I will offer
Oncotype score,
chemotherapy.
you will offer chemotherapy.
Yes,
So how will you counsel such patients that the patient has come to you, Oncotype DX score 19, and she reads the report, says it's intermediate risk. They do some chat GPT search, says that it's intermediate risk. I may avoid chemo. So how you are going to counsel her?
So as I said, na PonderX, there is a subset of the patients where it was a score of 16 to 25, or I think 17 to 25, less than 50 years of age, which benefited by addition of chemotherapy. Initially, they had 11 to 25, then they changed and they saw this is a subset. So, Oncotype DX score of 19 perfectly fits into the data set for me to offer them chemotherapy. Only issue comes that if this score would have been 10, Amol, then I would be in the soup.
So with the score of 19, even if it is intermediate, you are okay to go
Yes,
on with the chemo.
in patients less than 50, yes, we have the
Yeah,
data.
this particular patient.
Yes.
Yeah. So anyone else wants to say that, oh no, it intermediate score, I will not give chemo?
No.
Nobody in the panelist? Anyone else? Dr. Manjari or Dr. I think Neha? Anyone else
No.
wanting to
So
comment?
even though it's an intermediate risk, I think you need to discuss with the patient. And if she's very keen not to go for chemo, then you can discuss the risks. Otherwise, yeah, she's the case for chemotherapy.
So you will leave to the patient and say that, oh, you are
Yes,
not keen,
yes,
I'm not
yes.
giving. And the score is intermediate, I'm happy.
Yes.
Amol, this patient would be eligible for adjuvant CDK4/6 inhibitor also.
Yeah, that is a different discussion. We are coming to that, whether we
Fine,
can
fair enough.
have.
Sorry.
I'm coming to that. Okay, so moving on. What if the same lady is 62-year-old, two node positive, Oncotype DX score 22? You are happy to say no for chemo, or you will still give chemo? Dr. Safalta?
I will not give chemo.
Everything else is same. It is IDC, it is grade 3,
Hmm.
it is T2, and there are two nodes positive. Oncotype DX has been ordered by someone else. It has come as 22.
So if it is less than 25, there is like no benefit as such in these patients to give chemotherapy. But if it is grade 3, then in that case, I would suggest this patient that you may consider for 4-cycle TC also.
It is grade 3.
Yeah,
And
grade 3,
already shown
that's
in the
why.
history. It is
That's why.
grade 3
So,
here.
yeah.
Grade 3, CAS 67 30%.
Yes.
The age
So
has changed to
I would suggest
62.
this patient to take 4 cycles of TC. That's my clinical decision. And Oncotype DX, yes, it is like borderline-ish, and I would suggest her chemotherapy.
What do you mean the borderline-ish?
25, near 25.
Oh, so because
So
the
I
score
would
is
suggest chemotherapy in this
22,
patient.
suppose the score would have been 19 then, with the same lady, 62-year-old, two nodes positive. What is your lower cutoff to say no, we will not give?
It would be 16 or so something, but yes, in this patient, it will be very difficult to even to counsel to give chemotherapy, and it's a tricky situation for me. There will be people who will say, no, this Oncotype DX is 22 and it's low risk and there's no point of giving chemotherapy. But looking at grade 3, I would incline towards giving chemotherapy.
The Amish, 62-year-old IDC grade 3, two nodes positive. Someone else has asked for Oncotype DX and it has come 22.
The borderline, I would tell patient that 22 and 25 may there is not much of a difference, although the data says that you can omit chemotherapy. My personal clinical recommendation that Oncotype DX, as I showed in my slide, does not have too many of Indian representative data. So with grade 3 and with Ki67 30%, I would like to offer you full-blown chemotherapy if the patient is fit, 62 years of age, and not just 4 TC.
Yeah, she
Yes.
is fit. She is fit for chemo. So you will give a full flown. That means if required, you will give 8 cycles, 4 Anthera, 4 Tacron,
Absolutely.
rather than 4 TC.
Absolutely. 62 अभी बहुत दूर नहीं है अमोल हम लोग सबसे भी
Safalta wanted to give 4 TC. I'm of the opinion. I'm just giving my opinion.
Amol, as I said, I will try to convince, but I will also put in my prescription in writing, and I will tell patient that based on Oncotype DX recurrence score, and since you are postmenopausal, I will show them the graphs of 5 years. I will also show them updated Oncotype DX of 10 years. But I would say that since India is not represented well in Oncotype DX, I would offer you chemotherapy. That would be my stance.
So let me ask to all the panelists one by one about this particular question. Do you say no to chemo for intermediate Oncotype DX score? Always no, sometimes no, varies from patient to patient, or you don't do it only? Dr. Safalta?
It varies from patient to patient. It depends on postmenopausal, premenopausal. Yeah.
So I showed you postmenopausal. Here you said you will give. I showed you premenopausal. There also you said you will give.
So see, so patient to patient, like grade 1, grade 2, then I would not give. Grade 3, I will give. That's how. So it
So
varies from patient
basically,
to
your
patient.
decisions are already decided based upon clinical parameters. Then why are you doing the test?
So I did not do the test. Someone else did the test.
Okay, so the best answer is you don't do it only.
I will not do it. So grade 3 tumor, I will not do it.
Wait,
Happy
we'll go step
madam.
by step. Dr. Neha?
Sir, even I also see the patient varying from patient to patient. If young patient and if able to take the chemotherapy, I will like to offer the chemotherapy.
No, so basically, if the oncotype score is intermediate, because when it is low, when it is high, everybody knows what is to be done. When
Yes,
it
sir.
is
Yes.
intermediate, you will decide based upon what parameters. Patient is grade 3 IDC and fit,
So then the chemo is to be given.
irrespective of the age, even if it is 65.
65 is also, sir, young if the patient is fit.
So what is your definition of young? Do you think Safalta is young?
Yes, definitely.
So what is the
And
cutoff of the, what
65
I'm just
also the
asking,
people are
see,
young.
as I have put the disclaimer in the first slide,
So
we are having
Amol,
this discussion to learn. So what do you
Amol,
do
can
in
I?
your practice?
Yeah,
Dr. Amish?
yeah. So Amol has a very, very valid question here. I think this is the question where we struggle most of the time with Oncotype DX. So Amol, answer is my Oncotype DX intermediate score depends on the age. If the patient is say 65 to 67 years of age, ERPR in the otherwise all other parameters same, I would be okay if the patient doesn't accept chemotherapy. See, if you see these guidelines, we are nobody to tell them yes or no for chemotherapy. We tell them that you have, say, 1.4% additional benefit if you receive chemotherapy. If you don't receive chemotherapy, it is fairly okay because this is what the data says. But
Happy?
in
Oh, happy
females,
madam. Chalna?
in females who are less than 50 years of age, I would be quite happily ready to offer chemotherapy, especially between 15 to 25 score. Again, Amol, you and I, we know and we can discuss this on platform multiple number of time. My point is that if we are slaves to the data, I would say is that we have to follow the data. But in my practice, assuming somebody has a score of 14, a premenopausal, young 40-year-old fit lady who has grade 3 and Ki67 30%, I would definitely offer them chemo. So my decision in the intermediate risk depends strongly on the age and other parameters like nodal status, Ki67 and grade, and LVI if it is positive.
So, so taking a cue from this, what is the age above which you are not comfortable with giving chemo if all other parameters are saying yes, it is required, the patient is fit?
Chronological age of 65 and above. Otherwise, you see the fitness. I truly believe that we are now have a plethora of patients, Amol, where 59, 60-year-old are very, very fit patients. So these are the patients whom, you 60 would be my cutoff. If you have exact number, I would say 60 would be my cutoff.
Anybody else in the panelists wants to have
I
different
just
age
want to,
cutoff?
no, I'm not talking about hypothetically because I don't really treat patients. But from what I've discussed with various clinicians in the US also about, or in Europe about treating patients, typically for a postmenopausal woman, they would stick with 25 risk score, irrespective of node status. They will just go with the risk score cutoff of 25. Lower than 25, they would not give chemo. Higher than 25, they would give chemo. For premenopausal, node negative, they would work with the same cutoff. For node positive, they either don't do test or some of them do for 1 micrometers or something, and then I have seen the hesitation of whether to use 11 as 10 as cutoff or 11 as cutoff or 15 or 20. So then they really, I do see different opinions. Oh, if it is 16 I may give, but if it is 10 I may not. If it is 22 I may give, but if it is 19 I may not. So there are variations in that from what I have seen. That's just my
Basically, as far as the clinical practice is concerned, for an intermediate risk score of oncotype DX. If fortunately for the patient and unfortunately for you, if such patient comes to you, then you have to decide based upon the clinical risk factors. And as Dr. Amish has said, it is the age. Most of us are comfortable up to 65, but above 65, generally we discuss, and the nodal status and the IDC, grade and the Ki-67. But what the point here is that the oncotype DX score, or for that matter, any genomic risk score, ultimately is a complementary to the clinical risk factors, and that is what matters the most for the clinicians. So moving on, now comes the other
Dr.
thing.
Amol,
Yeah,
Dr. Amol, sorry, can I interrupt here?
yeah, please.
Dr. Amol, I am Dr. Vaishali. I am a surgeon.
Yeah.
So, although I do not treat the patients with chemotherapy, but I heard that whenever Oncotype DX is advised, and if it comes out as a high risk score, the Oncotype DX actually reimburses the half the amount. Is that true? That is one question. And in case if you order Oncotype DX and the risk comes out as intermediate risk, and you advise chemotherapy, then what happens?
So basically, as for the panel discussion, I have put a disclaimer. She has no cost issue. Very nicely,
No, but
Lily has said.
but
No,
in
Vaishali,
I mean,
Vaishali, they don't
yes,
return
sir.
half, they return 1 lakh.
Okay, they return 1 lakh. But in case if the score comes out as say between 16 and 25, she's a postmenopausal lady, and regardless of that score, you order chemotherapy, patient accepts. Then what happens?
So I will like to ask others who are doing more frequently oncotype DX about this particular situation. My personal experience is that I'm on the fourth. I don't do it only. So
Okay,
I
all
would
right.
prefer to stick to the clinical parameters. Dr. Amish or
Okay.
Dr. Safalta, do you have any such patient in which the reimbursement from the oncotype DX becomes an issue because you started chemo?
No,
What I
as
do
such.
now, Amol, sorry, Safalta, please go
नहीं
ahead.
sir, बोल बताइए sir, please.
What I do, Amol, I directly connect Oncotype DX with the patient. I
Okay.
do not indulge into it because, as you rightly said, I want to belong to be the fourth category where I don't want to do Oncotype DX. But unfortunately, in the real world, you end up doing in certain patients. And as I said, in postmenopausal female where I don't want to give chemotherapy, I am very strong on Oncotype DX because it validates my thought process. But there are reimbursement issues in what you said, but I tell the Oncotype DX company to directly deal with the patient. I do not interfere there.
Okay, so moving on. Now is the reverse problem. There's a 74-year-old lady, one node positive. Oncotype DX has been done. She has T2 tumor, IDC grade 3, the score is 35. Now, Dr. Safalta, what you will do? Unfortunately for the patient, the score has come 35, but she is 74-year-old. She has only one node positive. Will you give an ERPR strong positive? Will you give her chemo? Sticking to the guidelines?
If she is chemotherapy fit, I will discuss with her, and if she is willing to, I will give 4 cycles of TC to this patient. But if
Score
she is
is
little bit
35, so you will not give the
no full
required
dose,
all
no
4
full dose,
anthra and 4
no
taxane.
no full dose, and only 4 cycles of TC. If at all she is skeptical and then frail or not willing for it, then in that case I would will go for hormone therapy. From my side, if she says no, doctor, you decide what you want to give, and I am ready for that, I will offer 4 cycles of TC in this patient.
Dr. Amish?
So Safalta is a big fan of 4 cycles of TC. Safalta, please remember TC has a docetaxel.
Yes.
Docetaxel has a mortality.
So
I
I
have
give
seen those
with weekly
mortalities.
paclitaxel with cyclohexamide. I modify it.
And we do not have the data for that, Safalta.
Yes,
I know we
yes,
all do that, but when
yes.
you say 4 cycles of TC, please
Hmm.
be wary of docetaxel. I have lost
Yes.
patients with
Yeah, I
docetaxel.
don't give docetaxel, very few
Yeah,
patients.
yeah.
So, Dr. Amish, what
So,
will you give? You will
so
give
what
4
I
EC,
do,
4
I have
taxanes?
I have had two such instances last year where exactly the same scenario had come. One तो definitely नितेश का patient था जिनका उनको type DX तो होना ही था. So what Nitesh and I we discussed and what we planned that we will tell the patient if the patient is fit, no cost issues. We'll tell the patient that we will start with chemotherapy, weekly paclitaxel.
Mm.
Now we can replace paclitaxel with nab-paclitaxel in majority of the scenarios
Okay.
where you don't have the infusion related issues. In 12, both the patient, what happened by the time 12th weekly taxane was over, their performance status deteriorated, and we could convince them that let's not give you EC or AC anymore now. Both of them agreed. But assuming that they would have tolerated extremely well, Amol, I would have gone ahead and given them EC 4 cycles, because if the recurrence score is 35, there's a 12% to 13% benefit of adding chemotherapy to endocrine therapy. Now, here the real question comes that if I offer ribociclib to this particular patient, we do not have the data whether it takes care of high oncotype DX score.
No, we don't have data, and I'm going to discuss that. I'm going to discuss that regarding the special populations. But the correlation of the risk score and the whether to give CDK4 or not in this population, there is definitely no data. So now let us, for time being, let's talk about the chemo. We'll come to the CDK4 inhibitors. So you will give, and if the patient is fit, able to tolerate, you will start with taxanes, and then you'll go to anthracyclines. Anybody else? Dr. Veda and Dr. Neha?
Okay, so I'm a surgeon, so I don't give chemo. So I would go with what Amish says.
Okay, Dr. Veda, I think you're a medical oncologist, right?
No, I'm a surgical oncologist.
Okay, Dr. Neha?
Chairman breast services हमेशा surgical oncologist होते हैं, Amol.
Okay. So only two medical oncologists here, Safalta and Amish. So unfortunately,
You are also there, na, Amol?
What you will give?
No, I'm the moderator. Moderator is supposed to ask questions.
The Neha is also here. Dr. Neha is also a medical
So,
oncologist.
Dr. Neha, what's your thoughts on this? Dr. Neha, are you there?
आ जाओ.
I think she's not there. Okay. So basically, why I'm trying to highlight these situations, because more or less similar situation occurs in our practice, especially in intermediate score with oncotype DX. Sometimes the patient is not fit and the score is high, or sometimes the patient is fit but the score is intermediate. So we have to do a lot of clinical decision makings. Now, this is something which I have pulled out of the publications. And this is the forest plot that Dr. Amish was trying to show or trying to discuss, that what is the age and the correlation between the risk based upon the genomic risk profile. This is, of course, for oncotype DX. Now, the problem, any comments on this, Dr. Amish, on this forest plot?
Yeah, that's why I said, na, ke, I am of your team side, Amol. I don't want to do oncotype DX because there's so many confusing, confounding factors. With every year passing by, Amol, they come out with some data, some new follow-up, some update which confuses it further. So honestly speaking, based on if you have to believe this particular graph, then above 65 years of age, it doesn't matter about the score. But again, I said you have to look at ITT also sometimes. I don't have a true answer to this, Amol. If you have, please enlighten us.
No, I also don't have the answers, because the problem here is that this subgroup analysis, of course, are not powered. There is no sufficiently interaction, p-value interaction mentioned in the original publication. So the interference that we take out of the main publications of both for the oncotype DX as well as MAMA print, the subgroup analysis are unfortunately not sufficiently powered, nor the p-value of interaction given in any of the publications, including the NEGM publications. So this is again from the RxPonder. Dr. Safalta, any comment about this? This is RxPonder, postmenopausal, premenopausal, subgroups based upon the age, based upon the grade, based upon the tumor size, the nodes, and the recurrence score, in which they have included that 14 to 25 as one of the risk, rather than the 15 or the 16 onwards. So any comments on this particular forest plot, Dr. Safalta? Because when you discuss patients with 2 or 3 nodes or 1 node, then you are actually referring to this data.
Yes. So they have highlighted whatever be the grade, whatever be the higher grade or lower grade, because here you can see that intermediate and high grade in the postmenopausal female, the majority of these females. And if whatever be the score, like till 22, there is no point, like no benefit of giving chemotherapy. That's what I can understand with this. So, but in premenopausal, yes, there is a benefit of whatever be the grade and whatever, if at all, there is a higher score in that case, you have a benefit of giving chemotherapy.
So basically, if you assume this forest plot is statistically powered, then why to do the test in the premenopausal women? Because most of them are going to benefit by
Yes,
chemotherapy.
that's why we don't get a test in premenopausal women.
So basically, in all premenopausal women, none of the predictive score, because Oncotype DX has the maximum data, maximum published data. If that itself is failing, then what about the others?
Mm.
Okay, any comment on this, Dr. Amish or Dr. Neha, Dr. Veda, anyone else? Has any comments on this?
Dr. Neha, are you there? Have you joined?
I think Dr. Neha is not there. So unfortunately, Amish and Safalta are the one who have to bear the brunt of invisible Dr. Amula Khade.
Right. We
Hello, I'm here,
always.
sir.
Yes. Dr. Neha, please go
Dr.
ahead.
Neha, please, any comments on this particular forest plot, which is taken from subgroup analysis from RxPonder, which tested specifically node positive patients and intermediate risk scores, and they tried to find out what happens in various subsets in postmenopausal and premenopausal.
Postmenopausal and premenopausal.
I think your voice is echoing.
You must have joined
Is
on
it okay,
two
sir? Now?
devices, Dr. Neha.
Yeah, I have taken out one device. Actually, I was out with phone for some time. Okay.
So the question here is, if the premenopausal woman, as you see the forest plot, most of the things is on the left side of the median, saying that chemointegrin therapy is better, then why do you do the test in a premenopausal woman?
Yes, actually, sir, if the patient is node positive in premenopausal, we definitely go for a chemotherapy.
Without
And
doing the test.
I don't tell them to do the test, sir.
Okay, so at least half of the population is out from doing the test.
I don't. If the patient tells from their side they want to go, then only I tell, okay, if you want, you can go. But I tell them still there is a no use. You should go for the chemotherapy.
Okay. So moving on, the problem with this is that there is a subgroup analysis, not sufficiently powered, no interaction testing done, multiple exploratory analysis. These both publications are the best examples of how not to do subgroup analysis. And there is no gradient, as has been mentioned by Dr. Amish previously, that if the score starts rising about 25, whether the risk increases and whether there is any changes needs to be done. Based upon that, there is no such discussion ever happens. So basically, whether the score is 30, 35, 40, 45, 50, there is no change. Dr. Amish, you have any opinions on this? Will you change differently one patient with a score of 35, another patient score of 55? Or you'll get the same therapy for both of them?
Same, because as you rightly said, they have put it in sort of a fashion where we don't have the data 25 और 100 के बीच में क्या है. Just one paper में mention है with increasing score, there is an increase in the effect of chemotherapy, but nothing is quantified.
Dr. Safalta, for those who is chemo fit indicated one patient 35 score, another patient with a 45 score or 50 score, are you going to make a difference?
No, I'll treat them the same.
You'll treat the same. Anybody else? Any other opinion from surgical oncology colleagues? According to you, it should be different or same?
As of now, I don't think there's a difference. All high risk are put into one similar subgroup or same basket.
So that is another fault. Now, another major issue with the RxPonder is that they did not have ovarian function suppression as a mandatory thing. Very low OFS was used in ET alone arms. And if you see the hazard ratios of the RxPonder data and with the soft trial in which the OFS benefit is shown, they are similar. If you see the fine print of the RxPonder, actually the very young female paradoxically did not show clear benefits. So the question was raised when this was published, and now also it has been discussed, that whether the benefit of chemo in premenopausal is because of ovarian suppression or not because of the direct cytotoxic effect of the chemo. So, Dr. Safalta, what's your thought? Suppose there is a premenopausal lady, one node, and you have an RS score which is intermediate or high, you wanted to give chemo. Can you omit it by doing OFS and endocrine?
So we don't have that data whether we can omit endocrine
Oh, you have a soft
chemotherapy.
trial, you
Yes,
text trial data to show
but
that
in that
OFS
case,
benefit is there for
they have been
premenopausal.
given chemotherapy. They did not omit chemotherapy in these patients. So I would like to
So,
give, yeah.
so if you do, of course, the cross-trial comparisons and
Mm.
show that in our responder, not everybody got the OFS, the ovarian function suppression. So
Mm.
the main criticism of the paper was that probably the benefit of chemo is not because of the cytotoxic effect, but because of the ovarian suppression effect.
Yes, that's what is thought of, and we do follow it. We give chemotherapy with that thought process that it may be cytotoxic or it may be because of OFS
So
function
then why not
suppression.
give OFS, why not do OFS, surgical OFS one time, or maybe in medical OFS, less toxic than chemo?
See, we don't have that head-to-head data.
Dr. Amish, your thoughts on this, about this particular fallacy of the paper, our responders?
I personally think, Amol, is that both Taylor X and RX Ponder are over discussed. Then it should have been given importance about. That is what I think all the panelists are, including you, we all are saying that there is a very limited utility of Oncotype DX in the clinical scenario where we all believe that patient has high risk features of recurrence. So I would say is that these are all conjectures that we are assuming that के अगर OFS ज़्यादा patient को होता तो शायद hazard ratio change हो जाता. They're all conjectures. The data says this is there, and I think we have to take clinical scenarios in picture before we decide in the gray zone areas.
Yes, the similar criticism about the elderly patients also, that the problem in the elderly patients data, which is discussed in both the trials, most of the time when you talk about the OS benefit, there are competing mortality reasons like cardiac events or other any non-cancer related events. So not necessarily those with a high risk score where we are wanted to give chemo will have an OS benefit of taking the chemo because of the other possibilities of the comorbidities. So the point here is that even though you have an elderly patient with a high RS score, you need not treat based only on the RS score. You have to look at the patient, you have to do the geriatric assessment, and then only take a call. And what the criticism of the data is saying that the age is stronger predictor than the recurrence score, especially in an elderly population above 70. Now, this we have discussed that there is no difference in the chemo that is planned with the RS score of 40 versus 55. There is no gradient. And does the exact value of score above 25 matters? Dr. Amish has raised this in the beginning only, that unfortunately there is no such data to show or say that if one person has a score of 30 and another has 70, the one who's 70 is going to do bad and require higher treatment. Now, the important question, Dr. Safalta.
I have one small observation here in your previous slide. If you see the original first publication and first few publications, they had up to 29 was the intermediate and more than 30 was their high risk. Oncotype DX ka.
Now they changed to 25.
Then they changed to 25. So I really would be very happy to see 25 or 30 के बीच में क्या होता है करके.
That data will never come out because they don't have. It's like the PDL1 story. At least PDL1 has at least some data of above 50, but nobody knows what happens between 10 to 4, 10 to 20, 20 to 30, 30 to 40. The same way for the RS score also, the same thing is happening.
So true.
Now, important question, Dr. Safalta. Now, the same lady has a family history and she's BRCA1 mutated. Will that change your decision for adjuvant chemo when the RS score is, say, low or intermediate? Or do you do BRCA1 mutation testing for HR positive EBC, Dr. Safalta?
Yes, I do. If there's indicated
So
because of
suppose
the
if you have done it,
yes.
and the young lady BRCA1 has come mutated, and the RS, she is node negative, the RS score has come low. Will you consider for chemo because she's BRCA1 mutated and strong family history? high risk of recurrence? Or if you see this particular genomic test, none of them take into consideration BRCA or
Yes.
BRCA-ness.
They have not taken, so we have to use our clinical thought process. What
So
we
what
will
is your
do.
clinical thought process? That's what Dr. Safalta I'm asking.
Mm.
Suppose the patient is having low risk score of the oncotype DX, but he's BRCA positive. Young lady, will you give chemo?
So
You will not.
I would only consider according to the histological risk. If at all the patient
Yeah,
is having high risk,
she is IDC grade 3. She has one node and the RS
so
score
I
has
will
come
give
as low.
chemotherapy. I will give
RS score has
chemotherapy in
come
this
low risk.
patient.
RS score is 14.
No, I
1-4.
will give chemotherapy because grade 3 is there, lymph node is positive, young lady. So in that case, I will give chemotherapy.
Because she is BRCA positive.
No, this is not because of BRCA positivity. It is because the clinical risk, the histopathological, it is high risk. So I will
Okay,
give
so what
chemotherapy
about
in this patient.
she is N0 and risk score has come 14.
So N0 and there is no other high risk factor. It is grade 1 or
Grade 3 is the only high risk factor. Fine.
grade
And
3.
she is
In that
BRCA
case,
positive.
if it is grade 3, then I will give chemotherapy. If it is grade 1 or grade 2, in that case, grade 2, I will not give chemotherapy. But yes, I will counsel about for bilateral mastectomy and oophorectomy. The risk reduction surgeries I will advise.
So your decision for chemo is not influenced by BRCA mutation status and a strong family history.
No.
Dr. Amish?
मैं second opinion के लिए डॉक्टर अमीश के पास भेजूंगी.
That's okay, but what is his opinion? Let us ask him here only.
I agree with Safalta. Even in Olympia study, if you see HR positive patients in adjuvant olaparib were included only and only if they had a residual disease and their CPS-EG score was more than or equal to.
Olympia study had patients have received chemotherapy. So there was no discussion only of whether to give chemo.
Correct. So my point is BRCA1 mutated has got no bearing on the oncotype recurrence score, if that is what you are asking.
Yes. So my question is very specific. The patient's RS score has come low or intermediate, and she is having a strong family history, BRCA mutated, IDC grade 2 or 3, no node or maybe max 1 node. Will your decision be influenced by her BRCA mutation status?
Not at this point of time.
Anybody else in the panel like to comment?
Sir, I will also like to give the chemotherapy. Nothing to be done with this.
You wanted to give the chemotherapy?
Yes, sir. Yes, sir.
Sorry, you are not visible like me.
Yeah, I don't know, sir. I am not visible.
Okay. So basically, you will consider for chemotherapy, you think that the BRCA1, BRCA2 makes it slightly higher risk?
Yes, sir.
Okay. So let us see what is the data. And based upon BRCA and BRCA2 carriers tend to have generally higher recurrence scores. Validation trials did not routinely test the BRCA status. Distinct gene expression, there is of course a different gene expression biology in BRCA tumors. There is a limited prospective data. And I have pulled out one retrospective real world US data. And this is published. And what they have shown here, which I have put an arrow mark, that yes, ER positive, those with the low RS score also can have BRCA positivity. So at least ideally BRCA testing should be done. And especially in the intermediate risk score, one should consider giving some weightage to BRCA-ness or BRCA mutation positivity, especially if there are other risk factors are present. If grade 3 or not positive, top of that BRCA also positive, then one should err towards giving chemo, even if it is a low risk or intermediate risk. There is not much data at all. This is only single publication that I could find out, which is the retrospective data from the US, because that is the place where it is maximum.
That's what. Here, it is not because based on the BRCA-ness. It is about if the patient is having high grade, even if the low risk is there, that they suggest to give chemotherapy. That's
Yes.
what
So
we are
the
also.
point here is that,
BRCA,
first of all, BRCA testing should be done. Second, if the score is low or intermediate, and your decision is whether to give or not give, especially intermediate, then if the BRCA comes positive, maybe you can slightly err on giving chemo rather than not giving. Now, another interesting topic, can you use oncotype DX score to omit RT? Why only the medical oncologists suffer? Why not?
I have all the fun.
Yes.
Dr.
This is
Amol,
an interesting publication.
Dr. Amol,
Yeah.
there's a humble request. We have Dr. Veda us also. So we can take her valuable opinion where you find it suitable.
Yeah,
And
Dr.
no, we
Veda.
are not using Oncotype DX score to omit RT yet.
Yeah, Dr. Veda.
Yeah. But unfortunately, all your questions are related to medical oncology.
So that is why I
With a
came to the radiation data
topic,
also.
so
I
I'm a
pulled out this
comfortable.
paper that this is a very well conducted trial. They have taken postmenopausal patients between age 50 to 59. Of course, very small size tumors underwent BCS. They went Oncotype DX, and those who are less than 18, they enrolled into trial, and they prospectively study it. And what they have shown that one may consider omission of radiotherapy in those patients, even though underwent BCS, if the Oncotype DX score is low. So, Dr. Veda, all to you. What is your opinion on
Yeah.
this?
Okay. So as of now, we do have some not based on Oncotype DX, but
And
otherwise,
this is JCO publication. A full
yeah,
paper is already
yeah.
published.
And of course, it's from of the pioneers in radiation. And so nowadays we do have some data for omitting radiation, especially in 70-year-old plus and 65 plus, even in single node positives. But that is irrespective of the oncotype DX status. And maybe if you want to extrapolate that, we can consider this and look into further data.
Dr. Amish, your opinion? An elderly lady, low risk oncotype DX, BCS done. Can we omit the radiation?
Based on the IDEA trial has now 5 years of data.
Yes.
And JCO.
Can you ask Dr.
publication.
Neha to? Yes.
So
Dr. Sapalta, your voice is
Done, ma'am.
yeah, I think we can discuss this, and if the patient agrees, we can omit RT. The 5 years is not a small follow-up. In fact, all the approvals of all the genomic assays was based on 5 years data. But
we are missing Dr. Anushul Munshi here. Otherwise, we would have been a great debate about why only medical oncology should suffer because of oncotype DX. Anyways, now this is about a few things, special populations. Now, this is where Dr. Amish was talking. Can genome score be used to decide regarding use of CDK inhibitors in node negative patients? Dr. Amish, you have a node negative patient. I know there is a data from the ribociclib trial. If that patient has an intermediate risk score on RS, will that influence your decision for giving CDK inhibitors? I'm not talking about high risk. I'm talking about intermediate risk.
no, we don't have a validated data set comparing CDK4/6 and RS score as of now in any prospective manner. So my decision to use CDK4/6 inhibitor will not be based on RS score.
So what is your opinion about the Natalie trial in which they have some patients of high genomic risk with
So
node
that is for
negative?
eligibility criteria, na Amol. So if the patient node negative patient has a high genomic assay, anyway the patient is eligible for CDK4/6, na.
So you mean to say in
What
a
I'm trying
node
to say
negative
is that
patient with a high genomic risk, you will give chemo also because it is high genomic risk. You will give CDK also because it is there, the Natalie data. So where is the de-escalation? There is no de-escalation, even if it is node negative.
No, but why? I'm not the one who decides. I would be happy if we have de-escalation positive studies. But here, the question is not about de-escalation, Amol. The question is from 92% survival, can we go up to 100% survival? Can we cure all 100% of these breast cancer patients? I think that is where our endeavor is going on. Whether we end up damaging the patient is a second question, Amol. You also know that.
Okay.
But
so as
all
of
these,
now,
yeah.
if the patient, based upon the Natalie data, you will offer the node negative genomic high risk and CDK inhibitors is patient is willing to take. Dr.
Yes.
Sapalta, any other opinion?
No, I agree with Dr. Amish.
No, you
That
don't have to be afraid of him. He's not.
no. I had some other opinions before, so here I agree with him. So we are both agreeing with each other.
Okay. What about other histologies? Is there any genomic risk score predictive that you use for other histologies, or for other histologies you don't bother?
No, as such, there's no data about other histologies.
Correct. There is absolutely no data for other histologies. The recommendation strength goes down moment it is not an IDC. For mucinous and lobular, the recommendation strength is not 1A, and that has to be very clearly told to the patient. Another interesting factor, can this be used for neoadjuvant endocrine therapy, Dr. Amish? There are some papers which says that elderly lady with which has come to you after doing biopsy, high risk, it is a low risk, the RS score, and before surgery, we like to offer neoadjuvant endocrine therapy based upon the RS score. Have you done that in your practice, or what is your thought?
So it will help me, Amol. If I have decided that this particular patient is not for neoadjuvant chemo, and there is a large tumor, and the patient, if I have decided that I would want to offer neoadjuvant endocrine, RS score will help me take my decision.
Have you
RS
done
score
that in real
alone will
practice
not.
for
RS
anybody?
score alone will not.
Have you done that in real practice, any other patient?
I would repeat, Amol, I am not a big fan of Oncotype DX. But
What
if the
about Dr.
patient,
Beda? Dr. Beda, the surgical oncologist, will you like to consider doing before surgery neoadjuvant
No, no.
endocrine
As of
therapy?
no. As of now, we don't consider it as a new adjuvant tool. But yeah, we have heard of some data, but not very like it's not an RCT or a level 1 evidence.
Okay,
Dr.
so I think we are running out
Dr.
of
Amol,
time. What about male breast cancer patients, Dr. Safalta? Whether this should be used? We have residents listening to this. So what about male breast cancer?
So we will never have a data about for male breast cancer as such separately. So
What to do
we
in a
have to.
clinical practice?
So
Whether to send it or
I
not to
just
send it?
extrapolate whatever is the scoring system for the females. I use that score for the males as well.
So if the test is done, you
Hmm.
will use the same scoring system as that
Yes,
is done for
yes,
the
yes,
females. Dr.
yes.
Amish?
somewhere I don't agree with Safalta finally.
Arre,
Otherwise,
finally. Chalo.
See,
I
I'm very
consider.
good in creating disputes between people.
No, Amol, we love you because you are for science. You, one thing very good about you, don't care about anything else but science, and that's why we enjoy and we learn from you every time you speak. Coming back to your question, Amol, is I take male breast cancer a shade above female breast cancer in my clinic. Because of absence of subcutaneous tissue, they tend to be little more aggressive compared to female breast cancer. So intermediate risk score is something I would be little worried. Although I don't have a single patient of male breast cancer with Oncotype DX, but hypothetically going by, if I have a say score of 19 and a patient of say 60-year-old male breast cancer, I would, and other clinical features suggest I would end up giving chemotherapy to these patients more compared to female breast cancer. I don't have the data to back up my decision. You asked me what will you do in the clinic, and I told you that.
So
Dr. Safalta?
initially also I told you that my major of the decision is by the clinical parameter.
Correct,
So
correct.
like 19 score, if this is high risk, then I would err towards giving chemotherapy. So you agree with me in this aspect.
Yes,
Okay.
agreed,
So
agreed.
let us rush to the last few slides.
Dr.
For
Sorry, Dr. Vaishali here.
we are running out of
Just
time.
ask you in oligometastatic situation, like you were asking previously about use of genomic assays for decision about neoadjuvant treatment, right? So we had two cases wherein one lady was 40-year-old and she is strong hormone receptor positive, T2N0, but her PET showed a single bone met. Another lady, 60-year-old, T2N0, single bone met. In this situation, the 40-year-old lady was advised neoadjuvant. I mean, because it was oligometastatic, we considered her as a, potentially curative, and she was advised chemotherapy. A 60-year-old lady was advised CDK4 plus letrozole. So, do you think
So
what?
currently for oligometastatic, hormone positive, advanced metastatic breast cancers, the standard of care first line is CDK inhibitors plus hormonal therapy. So there is nothing wrong if that is being offered.
No. I'm just saying ki for a 40-year-old lady, would you be happy knowing what is her risk by doing some genomic assay? I mean,
No.
obviously, we don't have
No.
the data. We don't have any data for oligometastatic as of now. But would you like to have such an assay to decide whether she can be given endocrine therapy versus chemotherapy?
with grace of God, there is no such data as of now, and we are happy
No,
that
there
there is no such
data.
data.
I
So,
know. I'm asking, would you like to
Vaishali ji, one thing I have learned in last 2 years, please biopsy these. 50% of the patients don't turn out to be metastatic in the bone. Trust me, I have learned that because T2N0 ERP are strongly positive, lymph nodes are intact. Normally, systemic failure इतना मतलब systemic इतना ज़्यादा dissemination होता नहीं है. But if the biopsy is positive, yes, based on the other clinical parameters, whatever you decide, it is nothing wrong, as Amol mentioned about that. But I have learned my lessons. I try to do biopsies and prove that it is metastatic in such a low risk patients.
Okay, so I think we're running out of time.
Wherever
I
amenable,
think we are
definitely we
running out of time.
biopsy.
Yeah.
Wherever amenable, we definitely should biopsy.
Yeah. So these are slides about the HER2-DX and TNBC-DX. We'll keep it for some other time. Last slide, the take-home message: use genome-based assays selectively. Best data worldwide is with Oncotype DX, which is prospective and predictive. Indian data is limited. Clinical judgment is the best tool. It is not just a score. Start using it more often. It is free. Thank you. Thank you.
Very nice.
Thank you.
Thank you. Thanks. Bye.
Thank you,
Bye-bye.
Dr. Amol.
Thank you.
Yeah, this side, Dr. Prekshi, radiation oncology. So, since you put a question that whether we can omit RT based on Oncotype DX, and you showed the
Idea
data.
idea trial data, which is published in
Yeah.
JCO.
So this was by Reshma Jaxi and et al. And actually, it had only 200 patients,
Yes.
and they incorporated clinical findings along with Oncotype DX.
Correct.
So, the clinical factors and the histopathological factors, when they are taken into account, then yes, RT can be omitted sometimes, depending upon the comorbidities and all. And as Dr. Amish raised a valid point, that we have a very small follow-up of only 5 years. So based on it can be incorporated along with the clinical and histopathological factors, but only Oncotype DX right now is not the parameter based
So
on which we can
Dr. Safalta, this is getting recorded, right? We have on record
Yes.
radiation oncologist saying that the radiation can be omitted in the breast after BCS if it is a good clinical.
elderly lady.
Fantastic.
No,
Fantastic.
now
Thank you,
we
Dr.
have
Prekshi.
data
You are the
even.
pioneer in radiation oncology. Dr. Munshi will love you a lot. Thank you.
And all the before we end, actually, since we have been harping on the fact that we don't have Indian data, and Oncotype DX is definitely very expensive, there are very gray areas. So, what is the resistance to use can assist? I would like to know from all the medical oncologists on the panel. What
So
is that
I
which
will
is
start
lacking in
with
can assist? Yeah. Yes,
I will
please.
start because I have just 3 patients waiting outside. I'll have to leave
Sure.
after that.
Sure.
First of all, thank you, Amol. Always enlightening talks or the panel which you give. Ma'am, I said in my presentation also, Can Assist is also pitching themselves as an alternative to other genomic assays. I think they have to stop doing that. That is the first thing which I believe, and the guidelines also have to incorporate that this is can be the first thing. Second, in our clinical practice, we have been using Can Assist, even like especially doctors' mothers who understand the concept of this very well कि भाई 70-75 हजार की चीज के लिए आप 2-2.5 लाख रुपया क्यों दे रहे हो. Ultimately, it gives us a good validated tool. This thing. The only point which is goes against and something very influential people who come, it is Can Assist still have a retrospective data. It is validated retrospectively, and also if you see in a retrospective also, ma'am, if you see, they have taken, for example, they have taken say 200 tumor tissues from Rajiv Gandhi and TMH. Then they have taken the record kisko chemo mila hai, kisko endocrine mila hai. Then they have taken the record of CAB score. Then they have tried to match. Lot of heterogeneity in between gets lost. Lot of paperwork in between gets lost. So as a result, it does not have that robust. And again, I say that I'm very happy with the formation of Can Assist. We believe somewhere Indians also can make a breakthrough, but they will make a breakthrough. As of today, these are the deterrents for me offering Can Assist to every patient. That's why I said I can offer to almost many of my patients.
Dr. Amish, because we are going to leave, I would like to clarify this, that the studies that we have done, they're all, we get only tumor tissues to begin with the clinical parameters, because we need that to predict.
Correct.
And then we send our predictions to the hospitals, and then they give us the data of the patient's clinical outcome along with the treatment follow-ups. So we are not doing this in any haphazard manner. It's really very systematic. And it's very like that's the way the hospitals.
Dr.
The
Manjari,
point that Dr. Amish was
as I said,
making.
I'm honest. Amol will answer what I was trying to say. Amol, if you agree or
Yeah.
disagree with
The
me.
point that Dr. Amish is making, and which is most of the medical oncologists feel, we have the strongest data with oncotype-based MammaPrint. They have NEJM publications, large prospective randomized trials. Here we are talking about their subset analysis are not sufficiently powered, and all those statistical details. And when you compare that with a prospectively validated data, then honestly speaking, the one which is done prospectively has to be given more weightage. And that is why I still feel that the best data is still with the Oncotype DX because of whatever work they have done and whatever publications they have. But let us hope that in future we have better Indian data, and maybe we can discuss this. I think running out of time.
Another point here is we do have prospective. I just showed you the team trial, which is prospective randomized trial. Another ideal that is out, and more importantly, the proof of the pudding. Use of can assist breast in real world data, and survival of 98%. Of the 10,000 patients that are Oncotype has used, what percent are
The
Indian?
team trial also what you have said now, ma'am. Actually, it is prospectively collection of the data, but it is not prospective trial, ma'am.
But
You are
even blinded to the outcomes.
agreed. We are not saying that, ma'am. Again, trust me, ma'am, you are there. Today, my last line was, I would love to give everybody can assist. But as Amol and we are talking that we live in a real world, ma'am, somebody who has taken an opinion in US, and if that person comes to my OPD and says, okay, Oncotype DX yahan humko karana hai, I don't have the luxury of canceling Oncotype DX and writing can assist. But I'm sure whatever I have read about can assist for till now, you are going to be there, ma'am. I have no doubt about that.
Okay, and one last question. So the number of patients of Indian origin in any of this 10,000, 5,000 RX-funded TailoRx trials is minuscule. Indians are
absolutely.
So would you still go for that test?
Absolutely,
because that is the best. Again, I'm saying,
huh.
if the Canasys could have done a prospective data right from 2016, by this time we would have a 5 years prospective trial data out, which unfortunately not been done. And hence, the level of evidence, whatever said and done, will unfortunately be slightly lower side. But as I said, let us hope that we get in future more robust data, and let's hope for the best.
So on that note, I would just like to show you or explain to you, that the can assist, while everybody says we should be doing the prospective trial, I would really like to showcase this one slide where, RX Ponder and TailoRx both were not conducted by the companies who invented Oncotype DX, who developed Oncotype DX. It was done by National Cancer Institute.
Yes.
So I absolutely have no hindrance. I've always been saying to our National Cancer Institute, please go ahead and conduct it.
Absolutely.
The problem is that, madam, that bus is already gone. Now we are into HER2 DX, TNBC DX, and probably AI-based things. So I think that time is gone.
One thing I hear
anyways,
agree with
we
Amol,
can have in future similar such
one
things.
thing I agree with Amol, ma'am, Manjari ma'am. I didn't put it in my slides, but Amol is bank on right. Matt, 5 saal baad these genomic assays won't matter, ma'am. Trust me on that. How we are looking at medical oncology going forward. These genomic assays will have less and less uptake because you have more and more sensitive, and that's why your selection of those 5 biomarkers probably you would want to. I'm not a scientist, so I can only assume and tell you want to expand because you have covered all the 3 aspects of the tumor: stemness of the tumor, metastasis, and drug failure. I think that drug failure, drug prediction is going to be the future, ma'am. Genomic assays are very broad based. Oncotype DX का कोई भी paper उठा के देख लो, ma'am. We have thousands of faults right now. going by 2026 other paper publications. We are discussing because we don't have other things. The moment we have other things, these are not going to matter so much, ma'am. I am sorry, ma'am, but again, I'm telling you, I am very proud. I don't know about anybody else. I am very proud, ma'am. I am facing you today, somebody who is the pioneer, and where we are discussing with Oncotype DX and Mama Prints of the world, ma'am. Salute to you. I'll have to leave, ma'am. Sincere apologies, and I thank the organizers. I really, really enjoyed. Thank you so much.
Dr.
Thank you.
Sapalta, thanks for the panel discussion. I'll also have to leave, but see you next time. Thank you.
Thank you
Thank
all.
you, Dr. Amol. Thank you, Dr. Manjari.
Yeah,
So,
thank you.
So I would like to thank all the speakers, Dr. Manjari ma'am, Dr. Amish has left, Dr. Veda. We could not involve you much today. I had few questions, but since we are running short of time, I think we have to rush forward.
No issues. We'll have it for some other time. Yeah.
Yeah, sure, definitely.
Thanks, Dr. Veda. Thanks.
Yeah. Thank you.
Other speakers and panelists, Dr. Amol, he must have left, Dr. Neha, our very, very own Dr. Sapalta, for all these insightful sessions. Then thanks to all the delegates for taking out your time and joining. So I would also like to say that your feedbacks will help us to make the program much better. Then thanks to Dr. DJ Vijay sir and the team of FSIBC for being a part of these master classes. Thanks to Mighty Duo, your hard work, your sincere planning, and the seamless execution of all these webinars. Thanks to Sunidhi especially. Then thanks to everybody. And I wish you a very happy and colorful Holi. We'll see you soon after some time with the next webinar. Thank you. Thank you, everyone.
Thank you.
Good night.
Thank you.